Welcome, my name's Dr. Sarah Humphrey and I'm going to do a presentation on diagnosing advanced dementia mandate in a care home setting, Diadem. This is my declarations of interest. I'm a GP with an extended role in older people and I'm here today as the clinical lead for Yorkshire and Humber Dementia and Older People's Clinical Network. So I'm going to start with some brief background to Diadem. What is it? Well, Diadem is a tool for diagnosing advanced dementia in people who live in a care home setting. It's designed for people with an obvious moderate to severe dementia, not borderline, not early stages, not complex. So when I talk about moderate to severe dementia, I'm talking about the symptoms in later stages. People in the later stages of dementia become increasingly frail and dependent on other people for support. They may struggle to do the things they used to do, and their reactions are likely to be influenced by their environment and how they feel. People in the later stages of dementia often experience problems with memory, concentration, planning and orientation, problems with communication and mobility. They often experience eating and problems and weight loss, toileting problems and incontinence, and changes in their behaviour as their reactions to their environment change. Many of you will know the clinical dementia rating scale. In this scale, you will see the categories of moderate to severe, and the presentation of somebody with severe dementia is severe memory loss, only fragments remaining, often only orientated to person only, unable to make judgments or solve problems, often too ill to take part in functions outside their setting, unable to take part in any activities of daily living and hobbies, and often require help with personal cares and are frequently incontinent. That is who Diadem is designed to make a diagnosis in, that group of people. The Yorkshire and Humber Clinical Network designed a suite of templates that sit within System 1 and EMIS, and the Clinical Dementia Rating Scale is one of our templates. And I'll talk a little bit more about how you can access these. These are going to become national tools that will be available to every System 1 practice and EMIS practice around the country. In 2015, we brought together two existing tools that had been developed by two local psychiatrists, and we worked with some CCG dementia leads, and we developed a single tool. Initially, we agreed that the 6-SIT tool would be used as our cognitive screening tool, but as I'll show you, other tools are now in place. Why did we pick care homes? Reports estimate that between 70 and 80% of care home residents will have dementia, but many of them do not have a formal diagnosis. A third of people living with dementia reside in care homes and will never receive a diagnosis. Again, it shows it's a concentrated cohort of people. Some care home residents with advanced dementia or frailty are currently denied a diagnosis due to difficulty attending memory clinics, so people don't quite know how to manage them. There are examples of great care in care home settings, but several reports have highlighted significant variability, and some of that variability goes down to lack of a formal diagnosis. And finally, we know that the majority of people with advanced dementia die in care homes or hospitals, and a diagnosis can help inform the care at the end of life and support families to understand the dying process. Diadem is a non-specialist diagnosis, and people I know worry about that. They think about NICE guidance, so I thought I'd go through a few things about why we think in this case a non-specialist diagnosis is acceptable. For people with advanced dementia, and we went through what that constitutes, a referral to memory services is rarely desirable, as is often distressing for the individual and is usually unnecessary. It's not person-centred. Guidance for Commissioners of Dementia Services, published by the Joint Commissioning Panel for Mental Health, stated that patients who present with more advanced symptoms of dementia can be diagnosed and managed by primary care with or without community mental health teams. And if you want to look at that guidance, I've put a link in there. Non-specialist diagnosis in this setting is supported by our National Clinical Director, Professor Alistair Burns. And he sent a letter out stating that in 2016, recommending Diadem and Dear GP for GPs and appropriately clinical trained staff to use to diagnose dementia. The benefits of diagnosis. One of the most common questions I ask is, well, if all somebody's needs are being met in a care home, why bother? What's the point of diagnosing dementia at such a late stage? And I've got 2 slides here, which tell you how important I think it is. Firstly, it is a gateway to better care. I absolutely am convinced about that. It helps build understanding and relationships between the person living with dementia, care workers and family members and friends. People often stop visiting people living with dementia because they think that they don't remember. So what's the point? But actually, the sense of well-being left when they've had loved ones is a positive thing and helps those distress behaviours. It enables access to appropriate support, care planning, and in some cases treatment. So care plans are different and support is different for somebody living with dementia. It improves the flow of information during transitions of care. Many of you here will be working in acute settings, and you will know how different it is if you know that somebody already has a diagnosis of dementia. It will explain a lot of things. It will help you reduce the risk of a delirium as an inpatient and help you with your expectations of how you might rehab and help with care choices. It also prompts care home staff to consider prevention of delirium care plans and enables care homes to seek support from liaison services to understand and address symptoms of distress, sometimes called behaviours that challenge. And if we don't, we deny people access and deny people the ability to access care and think about best interest decisions. It can give the person with dementia the opportunity to share with family members and other carers their preferences. Now, that is less so with Diadem because we're obviously diagnosing somebody at the more severe end of their dementia, but that's a general one for a diagnosis of dementia. A diagnosis, even in the later stages, enables a person to access appropriate care to meet their needs, including an annual dementia review, part of the Quality and Outcomes Framework QOF for GPs, advanced care planning, respect, and DNA CPR. It also supports clinicians during structured medication reviews to think about anticholinergic burden, STOP, and antipsychotics with dementia deprescribing agendas. It also finally helps professionals and families to consider whether someone is approaching end of life and to make cares to ensure a good death. I'm going to talk a little bit about death and dying in dementia because I think that is one of the main reasons why Diadem is so important. Many of you will know there are 3 ways in which people with dementia die. They may either die from the complications arising from end-stage dementia, they may die in the early stages of dementia and die from another disease such as cancer, or they may die from a mixture of problems where dementia may not be the main cause of death, but interacts with other conditions and may complicate and worsen them. How do we know when people with dementia are reaching the end of their life? Well, a study of nursing home deaths found that most people with dementia were given a prognosis of more than 6 months. So we thought things were better than they were, but actually 71% of them died within a 6-month period. So death and dying is a normal part of living within a care home setting. So I've explained why we've done the tool and why it's so important. I thought I'd now take you through the tool so you understand how it works. So this is a paper copy of Diadem with 6-sit. You will see, so it's a single format, but we've now got different versions. So that's with 6-sit. This is with the GP cog, and this is with the mini cog. So we now have 3 paper-based versions, and we have a version in Welsh, which I haven't put here. We also have a version for System 1 and EMIS. And that's important because it means that GPs who are going out and doing things in a more remote fashion can input directly into their GP systems. You can join our Yorkshire and Humber gateway at the moment. Our association have access to all our suites of templates, including all the paper versions. This will soon become a national set of templates. We're working with TPP that this year that will be available to every GP practice around the country, and then following on with EMIS. So how do we actually make a diagnosis using Diadem? We have 5 criteria, and all of them have to be met for a diagnosis to be made. Firstly, consent. I often get asked about consent, and consent is important. You do need to explain to the patient and the staff what the test is for, why you're doing it, and explain that at the possibility at the end of the test that a moderately severe dementia will be diagnosed and what that means. Explain that if the results are positive, that this will be recorded in the patient's record and have permission for that to happen. If the patient lacks capacity to consent, a best interest decision should be made and consent obtained from families, carers or the care home staff. So I'm now going to take you through the 5 parts of Diadem. So part number 1 is around functional impairment. The person should no longer be able to live independently in relation to activities of daily living, such as washing, dressing, feeding, and attending to their own continence needs. And they should require prompting or supervision of staff to constitute a loss of full independence. So you need to be able to tick that box to be able to move on. You need to undertake a cognitive impairment screening tool, and the results of the screening tool should indicate an impairment. So that's with 6-sit. Mini cog. Number 3, very important, the corroborating history. The history should be of a gradual cognitive decline, typically lasting for the last few years, which is confirmed by care staff, relatives and medical records. Staff and relatives confirm that in their opinion, the patient consistently demonstrates both functional and cognitive impairment. It should not be a surprise that a diagnosis of dementia is made to the family and carers. Actually, what they should go is, yes, that all makes sense. It is not for borderline cases. Number 4, dementia screening bloods are normal, where they are clinically appropriate and the patient consents. If the patient lacks capacity to bloods, a best interest decision must be made and documented accordingly. If intracranial pathology is suspected, such as subdural hematoma or tumour, then a referral for a brain scan may be appropriate. Otherwise, where dementia is advanced, a differential diagnosis is unlikely to affect patient management and a scan is unnecessary. We are being patient-centred. Scans for the sake of scans and ticking a box should not be done. And finally, there are exclusion criteria. We do not think that there is any other underlying cause to explain what is happening, such as a delirium or a mood disorder or a psychosis. If we suspect those, we should not be using Diadem. So we can use these 5 criteria, and if all 5 are met, diagnosis of advanced dementia can be made. At the bottom of the tool, we have reminded people that those 5 criteria need to be met. We've put access to the guidance that says that you can use this mandate, and we've also given thanks to our 2 consultants who were at the core of Diadem in the beginning. We also have put access to the National Clinical coding set, which allows people to code appropriately. People often ask about use within the patient's own homes and what parameters are we setting. So I'll repeat, this is for advanced dementia only. It is not for people who have borderline dementia. We have pathways for people with suspected dementia. The tool could be used in somebody's own home, but I will remind you that clinicians who use this tool are responsible for ensuring that good post-diagnostic support is in place and that the diagnosis is communicated to families and carers. And I would suggest to you that there should be good reasons not to refer a patient to a MAT service in somebody's own home. Very few people probably fit the criteria for advanced dementia in their own home, though there will be some. What we want to exclude its use is prior to a referral for support from a community mental health team. If somebody is having distressed behaviours and you are struggling to manage them in primary care, you should be referring to CMHT for them to support you with the diagnosis and support with managing that distress. We do not think it should be used in hospitals. We do not think it should be used if you do not have significant robust evidence for a significant period of time for the presentation of cognitive impairment, and if you think that delirium is a possibility. There are some case studies where it has been used. There is no controlled trial research at the moment, but there are case studies. And there are case studies now, and there are cases now going on around the country, as we have now diadem pilots going on around the country with the new mandate from NHS England to explore the use of diadem. And the results of these case studies and pilots are coming in all the time, and I'll show you how you can access some of the information on the NHS Futures platform. Case studies for North Lincolnshire involved diadem in nursing homes and involved healthcare assistants completing the first two parts and a nurse practitioner completing parts 3, 4 and 5 with a dedicated GP support. So a very MDT approach. Their diagnosis rate pre-pilot was 58.5% and post-pilot 63%. Another case study in Buckinghamshire screened 290 patients over 7 months, and 120 patients, 41%, were found to be likely to have dementia. And it improved their dementia diagnosis rates, so 64.5%. I'm going to mention Dear GP because I think it dovetails very nicely with diadem. It was developed by the Health Innovation Network with support from the Alzheimer's Society. It is a simple paper-based tool which helps care workers to identify people who are showing signs of dementia and how they communicate that with their GP practice. So it's an enabler of care homes, whereas diadem is for professional working within the healthcare setting to make a diagnosis. This may prompt care home staff to contact practices to even think about who could potentially have a dementia syndrome. So we've aligned these and feel that they align very positively. And again, both of the tools are supported by Professor Alistair Burns. If you would like to have more information and see what's going on with diadem, a good place to look is to join the NHS Futures platform. There is a National Dementia Programme section. You can ask to join our workspace, and you will see at the very bottom of this page a blue bar, and when you can see what's happening with the diadem projects, and you can access support materials there, you can access the tools. So we'll be delighted if you would like to join the platform, and you can ask for support from people and you can see what other people are doing. This final slide gives you access to the tools and how you can email myself or Colin Sloan from the network, and gives thanks to our consultants. Thank you very much.